Good morning and good afternoon, depending on what time zone you're calling in from. And thank you very much for joining us today on this presentation of the Collaborative Practice Model for Family Recovery, Safety, and Stability. I'm going to start by giving you a little bit of historical context for the genesis of the Collaborative Practice Model. About 15 years ago, there were 5 national reports that were issued on the impact of substance abuse on the child welfare system. And across those 5 national reports, they noted some frequently cited barriers between collaboration between substance abuse treatment, child welfare, and family court systems. Primary among them was differences in values and perceptions of the primary client, timing differences in service systems, knowledge gaps among staff working in the systems, lack of tools for effective engagement in services, the intervention and prevention needs of children and lack of services for those, the lack of effective communication, data and information gaps, and categorical and rigid funding streams, as well as services and treatment gaps. Now again, these frequently cited barriers were noted almost 15 years ago in the 1998-1999 when these 5 national reports were issued. And not surprisingly, the intractable challenges of families that are affected by substance abuse, mental health, trauma, and other issues like domestic violence still have some very significant barriers to dealing with those challenges and effectively collaborating between the systems that serve them. Some of the suggested strategies that were noted in, again, those 5 national reports 15 years ago were developing principles for working together, creating an ongoing dialogues and efficient communication, developing cross-system training opportunities, improving screening, assessment, and monitoring of practice and protocols, developing funding strategies to improve timely treatment access, expanding prevention services for children, and developing improved cross-system data collection. These suggested strategies were also published as part of a framework for defining elements of collaboration that we as Children and Family Futures of the National Center on Substance Abuse and Child Welfare worked on with SAMHSA and CSAT, which defined those linkage points across systems. Where are those important bridges to build between substance abuse treatment, child welfare, and the courts? And that there were a variety of methods to assess effectiveness of collaborative work, which I'll get into in just a minute. So in the last 15 years, there have been a variety of collaborative practice and policy tools that we've developed to support effective collaboration between substance abuse treatment, child welfare, and family courts to improve outcomes for families affected by substance abuse, mental health in the child welfare and family court systems. Chief among them is the 10-element framework, which is what the collaborative practice model is based on, as well as a collaborative values inventory, a collaborative capacity instrument, a matrix of progress and system linkages, and screening and assessment for family engagement, retention, and recovery, SAFER, which is a guidebook model for developing effective communication protocols across systems. Again, I'm just giving you a brief overview for some historical context, and many of these collaborative practice and policy tools I'll discuss in a little bit more depth as we get into the presentation today. So again, in the last 15 years, we've developed a variety of practice and policy tools, and the most recent of which is a culmination of lessons learned over the last 15 years, is now the Collaborative Practice Model for Family Recovery, Safety, and Stability. It is not just a practice model, but it is also a toolbook, a toolkit, which includes resources, tools, handouts, publications, really a resource guidebook in that sense, in that it has some examples and lessons from the field as well. So it is available free to anyone on our website, and I provided the link below. And what I'm going to use most of the time during this presentation is to review the main concepts included in the collaborative practice model, as well as some key tools and resources that you can use. One of the foundational ideas that the collaborative practice model is based on is that many times agencies at the state and local level are encouraged to go collaborate with each other, but that term collaboration is such an amorphous, vague term that we strove in the collaborative practice model to be very concrete and articulate what does collaboration mean? What are those elements of collaboration, and what then would you do with your partners to, quote, collaborate effectively? And that's what the tools and resources and lessons from the field are presented in the collaborative practice model. So those 10 elements, There are 10 elements of system linkages in substance abuse treatment, child welfare, and family court services to create better connections, better bridges between the systems. And the collaborative practice model is based and organized on this 10-element framework. To briefly review, the 10 elements are organized into 4 categories. First is focusing on your mission, which is primarily understanding what are those underlying values and priorities that drive multidisciplinary work and drive the individual disciplines. Second is providing specialized services, the concrete screening and assessment, engagement, retention protocols, what exactly are the services that are being provided to the children in these families, what kind of community and family support is being patchworked together to provide all those ancillary services. Then separate from the specialized services, there's also some administrative functions within the individual agencies that can serve to connect those systems for better collaboration. And that involves the information systems, which includes data and communication protocols, as well as training and staff development system tools, budgeting and sustainability opportunities, and then working with other agencies, which is very much separate from identifying what services are needed. Working with other agencies is also about formalizing those working agreements. And we have some examples that I'll show you throughout the course of this presentation about how to do that. And then last but not least, certainly, is achieving positive outcomes for children and families. And that's all about, as a multidisciplinary group, identifying what are those shared outcomes and how can you as a group be jointly accountable for those outcomes. Now, I'll try during the course of the next hour and a half to go through each of these individual system elements in as much detail as I can while providing you, again, I really want to focus on some of those tools and resources that you can actively use in your work to enhance collaboration and identify the needs and support services for these families. There are also the PowerPoint presentation you should have received in an email about an hour before the presentation began. It is kind of a big file, so it might not have gone through. We got some undeliverable messages. So if you're having trouble accessing the PowerPoint, or if it did not come into your inbox, you can also access the PowerPoint presentation and this a playback on our website shortly after the presentation. And of course, you can always email us for any resources or tools that I don't get to in the course of today. So, jumping right in, focusing on your mission, the underlying values and priorities. Again, the first and primary element of collaboration is understanding what are those underlying values and priorities, and how those underlying values and beliefs may be left unaddressed can serve as barriers and challenges to advancing your collaborative practice and advancing your work with collaborative partners. One of the tools that we use as Children and Family Futures and the National Center on Substance Abuse and Child Welfare is the Collaborative Values Inventory, which the link and examples of questions I've provided here in this presentation. So the Collaborative Values Inventory asks questions such as, rate your level of agreement with this statement. People who abuse alcohol and other drugs have a disease for which they need treatment. Now, in this case, we had a small group, about 28 people, so it was a collaborative group at a state agency level that we administered the Collaborative Values Inventory. It's about 100 questions, so this is just one of them. And you can see that a large portion of people agreed with that statement, that people who abuse alcohol and other drugs have a disease for which they need treatment. Now, we also asked them, question number 7 of 100, people who abuse alcohol and other drugs should be held fully responsible for their own actions. Now, again, vast majority, agreed with that statement. So you can see how there may be a little bit of a tension here. People significantly agreed with that people who abuse alcohol or other drugs have a disease for which they need treatment, yet at the same time, they also strongly agreed, or somewhat agreed that people who abuse alcohol or other drugs should be held fully responsible for their own actions. So then what does that mean about the development of policies and protocols, eligibility criteria, screening and assessment for families who are coming to the attention of substance abuse treatment, child welfare, and other service agencies, in terms of then how do you hold someone fully accountable for their actions when they have a disease for which they need treatment? Other questions, again, in the Collaborative Values Inventory is, for example, there's no way that a parent who abuses alcohol or other drugs can be an effective parent. Now, here most people agreed with that statement, but we had some people who disagreed with that statement. And then we ask, the standard we should use for deciding when to remove or reunify children with their parents is whether the parents are fully abstaining from the use of alcohol or drugs. And again, here we have a large portion of people who agreed, but we had some people who strongly and somewhat disagreed with that statement. So again, you can see how this might pose somewhat of a tension in collaborative partners trying to work together, when some may strongly agree with this idea that a parent who abuses alcohol or other drugs can't be an effective parent, essentially, versus others who may really disagree with this idea that deciding when to remove or reunify children with their parents, the criteria should be whether or not the parents are fully abstaining from alcohol or other drugs. Again, what does that mean about the kinds of policies and protocols and criteria for removal and reunification? And not that there are any right or wrong answers to this question. The goal is to, in a non-judgmental, objective way, put out on the table that as a multidisciplinary group, we have varying opinions. We have varying degrees of values and beliefs that are the foundations of our work, and the challenges that we may be facing as a collaborative group in working together can be somewhat attributed to our varying values and beliefs, and that's something to recognize, acknowledge. But once you've put out on the table that those areas of disagreement exist, then you can focus on, so then where do we agree? Where do we have areas where we can move forward with and leverage in those areas of agreement? And then some of the tools that we have to facilitate that, number one, is the collaborative values inventory, which are the questions that I just reviewed. But also we have examples of sites who have conducted developed their own joint mission statements, and who have created statements of cross-system values and principles. Let's see if I included a hyperlink here, so let's see if it works if I pop it up here. Okay, so one of the examples that we have is a synthesis of cross-system values and statement of values and principles from a national perspective. We had several national organizations, including the Child Welfare League of America, the National Council on Juvenile Family Court Judges, the National Indian Child Welfare Association, the National Association of State Alcohol and Drug Addiction Directors, the American Public Health Human Services Association, as well as Children and Family Futures, came up with this cross-system values of statement of values and principles, where we outlined then in each of those areas joint accountability and shared outcomes, principles of daily practice, information and data sharing. Where are those areas of agreement that we could identify between a variety of, in this case, national organizations who clearly come from varying perspectives of who's their client and what's their mission and mandate? But where are those areas of agreement that we can leverage and commit to as a collaborative group? And one of this can be used as a tool in your own collaborative groups, in your own states and counties and tribes. You can look at this cross-system national perspective of values and principles and modify it to meet your own collaborative group's needs. And as the National Center on Substance Abuse and Child Welfare, and as Children and Family Futures, we've facilitated that kind of cross-system values and principles statement development in other sites. And so we have some examples in the collaborative practice model for you to see. So again, the collaborative values inventory, the collaborative capacity instrument, and I've again provided you a link to where you can find these tools to review. And again, they're available free of charge, and all you have to do is just call us, and if you'd like some more information about how you might be able to use that kind of a tool with your collaborative group. Okay, the next element of the collaborative practice model is screening and assessment. So within the context of providing specialized services, how do you perform screening and assessment in a collaborative way that improves outcomes for children and families? The first part of understanding screening and assessment is that that the collaborative practice model outlines is that screening and assessment is conducted for the purpose of engaging and retaining clients in services. So in screening and assessment policies and protocols, you want to focus on, does the family have a substance use or child abuse or neglect issue? If so, how urgent is the issue? What is the extent and immediacy of the substance use or child abuse and neglect issue? And how do the systems need to respond to the substance use or child abuse or neglect issue? One of the questions that we very frequently got as in the first couple of years of the National Center on Substance Abuse and Child Welfare was, what's the right tool for screening to identify when substance abuse or mental health issues are prevalent in the family? What's the right tool as a treatment provider? What's the right tool to screen for child abuse or neglect before I make a report? And we recognize that in all of these questions that we got from stakeholders across the country, that there are a wide variety of valid tools that can be applied for that purpose of screening, but that when you look at screening and assessment for the purpose of engaging and retaining clients and services, it's not so much the tool specifically, but it's the team that's brought together. It's what then happens to the results of that screening tool that you've used? Who have you engaged as partners to be able to ensure that services are readily available and that the screening and assessment then leads to immediate access for services? And that, along with some examples, are what are outlined in the collaborative practice model. So we have some brief synopses in the collaborative practice model about how some states, like the state of Maine, for example, have used the UNCOPE as a universal screening tool statewide in their child welfare agencies. And some examples from New Jersey on their Child Protective Substance Abuse Initiative. But very much relatedly, and I'll come back to screening and assessment, but again, because screening and assessment is outlined in the collaborative practice model for the purpose of engaging and retaining clients and services. I'm going to jump ahead to engagement and retention. Part of engagement and retention is primarily understanding the cross-system process for referrals, engagement, and retention and treatment. So one of the tools that we have provided for you in the collaborative practice model and available on our website is a pathways of communication template. So the way that you use this tool and the way that the screening and assessment is connected to engagement and retention and services is first and foremost understanding the process that each of your agencies go through to screen, assess, diagnose, and then do case planning or treatment planning for the family, for the children, youth, and families. And then how those case plans and treatment services are monitored to the end of the child welfare case or to the completion of treatment services. And how at each of these points in your individual system processes, information can be shared between you and your collaborative partners to enhance engagement of families and services and enhance your ability to ensure that families, once they are identified and referred for services, are actually accessing those services and moving through the treatment and child welfare process appropriately. An example of how we've done this before is in one state, in one community where we worked, we outlined the adult probation, juvenile probation, alcohol and other drugs, and child protective services process for screening, assessment, case planning, monitoring, and completion, and then outlined, again, where are those points in the process at this point currently where information gets fed back and forth, and then thinking through then how this differs from how many pieces of information could be shared and for what purpose. So again, connecting the dots between if each individual agency is already conducting their own process of screening, assessment, and engagement, how do you share information in a way that shows that you are working together as a team to support the families? Then again, connecting screening, assessment, engagement, and retention, first is understanding the process, but then also measuring and changing the process for referrals, engagement, or retention and treatment, recruiting and training staff, as well as jointly monitoring family progress. One of the tools that we've provided in the collaborative practice model, and that, again, we have supported other sites in working through in their collaborative practice groups, is what we've been calling the drop-off analysis. And it's a assessment tool that we use with sites to help work through, now that you have an understanding, or now that you've laid out what your system process is, let's connect some actual numbers to there to find out what do we know about how families are progressing through services, through handoffs between systems, and then what do we know about what are the outcomes we're actually achieving at this point. So this is a hypothetical. These numbers are not based in, these aren't drawn from any particular state or county. These are hypothetical questions because, again, this is a tool that we often use and facilitate sites in helping to work through. So if, for example, you had 1,000 children or 500 parents who were referred to Child Protective Services for child abuse or neglect issues, through screening and through a screening measure, through a screening tool, you identify that, let's say, 60% of parents need assessment, so that's 450 of the parents that are in the system or involved in child welfare services. And let's say about half of those that were identified as needing an assessment actually show up for their assessment, so you're down to 225. And then of those that are assessed, let's say 80% of them need treatment, or 180. Now these percentages are kind of best guesses based on research and evaluation studies that we've conducted and national studies. So again, this is a hypothetical process by which we encourage sites to look at their own data in their own state or tribe or local jurisdiction to identify then what are your real numbers that you'd associate here. So if, for example, let's say 80% need treatment, let's say about half of those actually go to their first treatment session. And about national averages are about 30% of people who enter treatment services complete their first 90 days in their first treatment episode. So that's down to about 30. And then if you try and connect back then, of those 30 that were of these original 750 parents that came to the attention of child welfare services, if their children were removed, about how many of them reunified. Say, we'll just put an average in there, let's say about 50%, so 15. So again, this is a tool that we use with sites and that we have provided to you here in the collaborative practice model as an example for how you could walk through your individual agencies and work with your work between your treatment and child welfare counterparts to understand how many parents come into the system, how many parents actually end up accessing treatment services, and then what do we know about those parents who actually reunify with their children. One of there are two key concepts that are involved in here in the drop-off analysis that we outline in the collaborative practice model. First is obviously understanding how your current system works. What do you know about how many parents are actually reunifying? What do you know about your current status? Then, with that knowledge, how do you go back and make adjustments to increase these percentages? So if, for example, of the 750 parents, 60% of the parents who need assessment, half of them go to an assessment, maybe you want to start working on that percentage. How do you want to how can you insert an appropriate intervention to ensure that all 450 who are identified as needing an assessment actually go for an assessment, actually receive their assessment? One of the processes that we often find is that the lag time between identifying that a parent needs an assessment, scheduling the appointment for an assessment, and then actually receiving the assessment, that time delay can partly be attributed to why there's such a, quote, drop-off in the number of parents that actually receive an assessment for treatment service needs. So how can you, as a collaborative group, work on reducing that time so that perhaps you can increase that percentage? So then hopefully the theory then would be that you would be able to enhance and increase the number of parents who are completing services and then reunifying with their children ideally. So again, a hypothetical exercise that in a variety of states and counties we have used to help them walk through what does your current system do, and then test out some key practice and policy changes to help increase the numbers and then increase the positive outcomes for children and families. Some examples that are, then we have several examples that are provided in the collaborative practice model about some kinds of interventions that other states and counties have and courts have put in place to increase their number of clients who are accessing services with an understanding of where they were experiencing the most challenges and the highest, quote, drop-off. And then, of course, some publications and resources that are available to you. Okay, the next element is providing specialized services for children. Part of understanding what kind of services are needed for children is based in understanding how many children are we talking about. And again, this is, there are a variety of ways that children can be defined as living with a substance-dependent parent. They were living with a parent who used an illicit drug in the past year, used an illicit drug in the past month, dependent on alcohol and or needs treatment for illicit drugs, lives with a parent who is dependent on alcohol and other drugs, or alcohol or on illicit drugs, or needs treatment for illicit drug abuse. And these numbers are indicating the millions of children. The number that we focus on the most is 8.3 million children each year live with a parent who is dependent on alcohol and or needs treatment for illicit drugs. 8.3 million is about 11%, which is, you know, when you think about elementary school classrooms of 30 kids, that's about 3 children in each elementary school classroom who is going home every night to a parent who is dependent on alcohol and or needs treatment for illicit drugs. So then again, what does that mean about appropriate policies and protocols to ensure their safety, and what merits, what risks are associated with that, and what would merit child welfare intervention? Certainly not all of these children need intervention, but what criteria is set then? Understanding also how many children are affected by prenatal substance use. These are numbers that are published by the Substance Use and Mental Health Services Administration through the National Survey on Drug Use and Health, that percentages of women who report substance use by pregnancy trimester. And you know, they report both illicit drug, alcohol use, binge alcohol use, as well as cigarettes. And one of the positive things you can note is that the percentages do drop as women progress through second and third trimester, but that there is still a percentage of women who continue to report illicit drug use, alcohol use, and perhaps very concerningly binge alcohol use in the third trimester. So understanding how many children does that mean are those children that are being reported as substance-exposed newborns to Child Protective Services. One of the points that is outlined in the collaborative practice model is that, again, going back to these children affected by prenatal substance exposure, often policies and practices tend to focus on identification at birth. The hospital, we often have gotten questions about what's the appropriate screening method for or cutoff levels for urine toxicology for the infant or for the mother, and how do you ensure that you test both the mother and child at birth, and how do you work with the hospital staff? And while certainly that is one key area and time frame for identifying whether or not a family is affected by substance use and if the infant was prenatally exposed to substances, but there's a continuum of 5 points of intervention that are outlined in the collaborative practice model that begins with pre-pregnancy awareness of substance use effects, prenatal screening and assessment, and then initiating enhanced prenatal services if indicated. Clearly, the identification at birth is a key point in time for appropriate intervention, but that there is also the need to create system linkages to identify when infants have been exposed to substances prenatally, that their needs are responded to, as well as the treatment needs of the parents. And then as the infants who were prenatally exposed progress through preschool, childhood, and adolescence, that certainly their needs don't diminish over time, and that very often children who may come into the child welfare system later as preschool-age children or adolescents may very well have been prenatally exposed to substances if substance use is an issue in the family history. So what the collaborative practice model outlines is this 5-point intervention framework, and we've provided some examples in the actual document of some sites who have begun working on those individual points. That's not to say that any one particular state or community has all 5 points of intervention connected in an effective patchwork, but that understanding that collaborative practice is about identifying why you want to focus on one particular intervention point and how you communicate that and gather the right partners in your collaborative group to effectively focus on one of those intervention points and recognizing that it's one intervention point in a larger continuum of services. And then I have some listed here, some publications, which again are listed for you in the practice model, so I won't go through those. And providing specialized services, community and family support. Now this is about, overall, that obviously there are a myriad of interconnected, interrelated components to services that are needed by families who are affected by substance use, mental health, and involved in the child welfare and family court systems. I don't think anyone would disagree that they have significant service needs and that providing services for these families requires inherently partnerships and collaborative arrangements with partner agencies. One of the developments in the field of family-centered services includes a better understanding of how family-centered treatment services can coexist exist on a continuum of services. So the continuum begins with women's treatment with family involvement, women's treatment with the child present, women and children services provided together, family services, and then family-centered treatment. So I won't go into huge detail here, but that as both child and family and adult-serving agencies are developing a better understanding of what does it mean to be family-centered, in the treatment world there's also a corresponding development of what family-centered treatment means, in this case particularly for women, but certainly for any adult who has children and are also accessing treatment services. And as you think about if you are a treatment provider or if you are working with treatment providers, where they might fit on this continuum of family-centered, family-based treatment services. This is certainly a developmental trajectory that's happening in the field, and there are some examples that we provided in the collaborative practice model of what family-centered treatment looks like. But again, this is a developing field. Part of that developing field is also, again, understanding the interrelated components from the clinical treatment services at the core to the clinical support services for treatment, community support, and then larger community support. That clinical treatment services address the medical and biopsychosocial needs. Again, I'm not going to go through each of these individually. These are provided in the PowerPoint handout and in the practice model as a resource. But that there are, as I said at the beginning, a myriad of interconnected components to family-centered treatment services. And again, I don't think anyone would disagree that all of these service needs, housing, childcare, transportation, recovery support, vocational and educational services, faith-based organizations, that these are all necessary partners in effective collaboration and identifying effective services for families. And that there are also between women, children, there's also the clinical treatment service needs of the children and the clinical support service needs for children as well. Essentially, as outlined in the collaborative practice model, that working with the community and supporting families is inherently about recovery management, recovery community services such as self-help, recreational activities, drop-in supportive centers, mutual aid and peer support, family strengthening, child care and faith-based organization supports, as I very, very briefly reviewed. And we've provided some examples of how other agencies, other states and communities are putting together that network of supports for family services. But as I said, I want to focus today on some of the tools that we have available to you. And one of those that is included in the collaborative practice model is this development, a template for an inventory of available services. This might be sort of intuitive, I guess, that if you know that your families, the families that are coming to access your services have a variety of needs, that you might want to do an inventory of what services are available in your local community, and identifying how they match with the needs of families, those partners that you have, what kind of services they have available. And then as really part of just general basic collaboration, talking with potential collaborators to develop working agreements or MOUs, identifying what criteria partner agencies have for accepting clients, and then establishing agreements regarding the flow of information, feedback between agencies. And this is, I think, one of the things that the collaborative practice model highlights here is that it's a combination of identifying what services are needed, but then taking the additional step to actually develop those working agreements or MOUs to negotiate with those collaborating agencies who you want to engage as your partners. How then do you formalize the flow of information and the referral of clients so that it's not just a handoff, but a warm handoff for families, that you as agencies and staff and leaders have worked out the process for how families work between one agency or another, and that families recognize this in the warm handoff that they get between your agency and your partner agency. That, again, going back to that concept that I mentioned before, it's the team, not the tool, that it's, while the individual services are certainly important and that there are critical services that families need, it's as important that your partnership and that the families that are receiving services feel that there is a team and a network of people who are supporting them, not just individual agencies that they have to individually negotiate and network with. And then we have, again, some examples that are provided in the collaborative practice model. So now we start to get into those, as I mentioned earlier, the collaborative practice model begins with understanding values and principles, focusing on the mission, and then providing specialized services, which we reviewed was screening and assessment for the purpose of engagement and retention, services for the children, and then working with community partners. And that's all part of the providing specialized services. Now we're into the piece of the collaborative practice model that's about connecting systems for collaboration. These are the administrative agency level responsibilities for what, in this case, first, what sort of data systems and information sharing it needs to be able to be resolved between the partnership to have effective collaboration that improves outcomes for families. The key concept here in effective communication information systems is first identifying the content, methods, roles, and responsibilities in cross-system communication and actually developing a protocol that outlines those components. Linking information system databases to track progress of children and their parents to determine whether families achieve goals. And certainly one of the barriers that we often hear is confidentiality issues between systems, but that when the content, methods, roles, and responsibilities of partners are clearly outlined as part of a communication protocol, the issues of confidentiality tend to be mediated when it is very clear between partners what information is being shared and for what purpose. We often find that when talking about information sharing, both data and individual client level information, that one of the underlying fears is that not wanting to share information, partly because of not knowing what will happen to the information once it gets released, and certainly wanting to protect HIPAA and 42 CFR confidentiality requirements, and the tools that are outlined in the collaborative practice model are, again, how to share information in a way that is specific and that still protects confidentiality. One of the ways to start that conversation about what information needs to be shared and for what purpose is to identify how many clients we have between our individual systems. In one community, again, we worked with the probation office, a juvenile and adult treatment, public health nursing, their dependency drug court in the area, perinatal alcohol and drug services, and child protective services. And we went through and identified how many clients might there be, because obviously not every community has the ability to track how many clients exactly are in each other's data systems. You may have an idea of how many clients are referred, but certainly there are data system advancements that need to happen for effective client tracking. But again, just to start the conversation, one of the tools that we use is just putting side by side how many clients may be in multiple systems at the same time, and how these referral linkages happen, who refers clients to which services. And so when we did this analysis of where all the information is being shared, it became very clear how many families are, for example, in this case, alcohol and other drug services referring to or communicating with related to perinatal services, and how many juvenile probation clients are being referred to alcohol and other drug treatment services, and what does that mean about we're not sharing information or data on all of our clients. We're not opening up our databases for public view, but that we are being very specific about exactly which clients we want to share information about and for what purposes. Oops, one more information flow. And then we provided here some examples of, going back, some examples of some information data sharing protocols, and then some publications and resources for you, including some webinars and examples of memorandum of understanding on information systems and data sharing. These are all provided as resource tools that are incorporated into the collaborative practice model. Again, the collaborative practice model isn't just a practice model, but it's a toolkit and a resource guide. So in the interest of time, I'm not going to go through each of these individual resources, but introduce some of the concepts that are in the collaborative practice model, and then you have the opportunity to download the entire practice model with all of these links as live links in the PDF. I do want to focus on one of the other things that SAFER was one of the publications that I mentioned at the very beginning. Screening and Assessment for Family Engagement, Retention, and Recovery is one of the collaborative policy and practice tools that was developed. It has pathways of communication, templates, and then we also have a, in the interest of, again, starting that conversation of how would you go about identifying the number of clients that may currently be involved in multiple systems at the same time. We've provided for you a substance abuse child welfare systems data profile worksheet. So a worksheet where you can actually drop in some of these numbers and start to create your own map of how many clients you're talking about. Okay. Then further, moving on, the next element of collaboration being budgeting and sustainability. Now, certainly, the major theme that we hear from collaborative groups and individual agencies across the country is that budgets have been decimated, that staff have been significantly cut, and that there is a urgent and necessary focus right now on trying to do the best with what funds are available. And one of the ways to frame that in figuring out then how do you sustain the most effective pieces of the projects and services that you have. And part of that is identifying then what are the most effective pieces of the projects and services that you have available, and how can you work together with your community partners to develop a marketing plan, to engage others who might want to be involved in providing those effective services. And that while there are the total resources that partners need to sustain, that the innovations and what can be leveraged from other sources. So budgeting and program sustainability is interconnected with some of the other elements of collaboration, in that we are also at the same time talking about data and information systems, screening and assessment, and engagement and retention, in that in order to sustain the most effective parts of your program, you need to identify how do you identify what are the components of the services that you're providing that are most effectively engaging and retaining clients and services, and how do you have the data and information sharing protocols in place to be able to document in actual data and treatment and child welfare completion outcomes to justify that these types of programs that you're trying to sustain are the most effective. The political and community resources needed to sustain the innovation, providing that it has support in the community that extends beyond the sponsoring agencies. That, again, is a key point in the collaborative practice model about budgeting and program sustainability, that there are a wide array of resources, funding in the community, but that part of the onus on the collaborative group is to struggle through the data and information sharing communication protocols to identify what are those most effective services, so that you can make the case to justify continuation, especially in these very difficult economic times when some of even the most effective programs are being cut. We have some examples of how some other communities have developed marketing plans and used budgeting as a way to identify what are the most effective and programs for sustainability. Some of the resources that we have is, again, as I just mentioned, a funding source template and a marketing your program, creating the sales document, a cost rationale and cost analysis discussion guide. These are all tools that we've developed as part of the training and technical assistance that we've provided to sites to help them understand what are the most effective pieces of your programs and how do you use cost offset data to be able to justify continuation of services when you're able to justify that the services that you're providing in even the short-term year, in a year or 2 year time frame, can witness some cost offsets by, for example, reunifying more children faster by providing effective services to the parents. Those kinds of that kind of information carries heavy weight with state agency leaders, county board of supervisors, who are trying very difficult to get through these difficult times to identify what services should or shouldn't be cut and why. We also have just a quick review for you, the Funding Family-Centered Treatment for Women with Substance Use Disorders. Well, this is a publication that was developed through the Substance Abuse and Mental Health Services Administration that, again, we provided the link for you in the collaborative practice model. It has a very basic overview of different ways of blending and braiding funding for family-centered to achieve family-centered treatment services, as well as a very detailed spreadsheet table that outlines a whole host of federal, state, and local funding streams and how they can be used. So for any of you listening to this who are funding, budgeting gurus who really want to know all the different funding streams that can be available in your state or community and what their uses are, the Family-Centered Treatment for Women with Substance Use Disorders publication is one key resource for you. And then again, going back to the funding source template, is one of those kinds of inventories similar to like I mentioned before, as you might want to create an inventory of available services to identify what services are needed for, what services are available for the needs for families and children in creating community and family support services. That in budgeting and program sustainability, we also provide you with a template to conduct an inventory of funding sources in your individual state or local jurisdiction. What funding is available in the larger community, how are those funds allowed to be used, and using that as a discussion point with your partners. Okay, moving right along. The next element of the collaborative practice model is training and staff development. Let me stop for a second and just make one statement that the intent of the collaborative practice model is not to say that all of these elements need to be a primary focus of collaborative work between groups, but that these are opportunities to look at where are, of these 10 elements, where do you think you can get the most movement forward in your state or community? Where can you look at the kind of relationships that you already have with your partners? Who are your partners, and where would you as a group want to prioritize work for the next year, for example? So this isn't to say, or to this isn't intended to be overwhelming to anyone that you have to do all of this, but that depending on where you are in your collaborative group and who you have at the table, that the 10-element framework is a way to help you be very concrete and then prioritize what element you want to move forward with. So that being said, the next element is training and staff development. And this is one of those, as Children and Family Futures and the National Center on Substance Abuse and Child Welfare, we often get requests to come out and do training on, train our child welfare workers on the impact of substance use in families, or train our treatment providers on child maltreatment and identifying signs of child abuse and neglect. One of the responses that we often have to those kinds of requests is that the most effective way to ensure that training really leads to practice changes is that the training should be designed around what you want people to do. That there are different levels of training and different purposes for training, and that's part of what's outlined in the collaborative practice model. As for fundamental training on that level of awareness of the issues and identifying some first practice steps that can be taken, as the National Center on Substance Abuse and Child Welfare, we've developed 3 online tutorials that are currently available. The first is Understanding Substance Abuse and Facilitating Recovery, a guide for child welfare workers. The second, Understanding Child Welfare and the Dependency Court, a guide for substance abuse treatment professionals. And then finally, Understanding Substance Use Disorders, Treatment, and Family Recovery, a guide for legal professionals. So across all of these 3 online tutorials, you can see that we've taken a spin of teaching one system about the other, so that to enhance collaborative work by not only identifying what your role, in this case, for example, as a child welfare worker is, but how do you as a child welfare worker then understand substance use and facilitate recovery. And part of the information contained in this tutorial, for example, includes how do you work with your treatment colleagues. Similarly, for the substance abuse treatment professionals, how do you work with your child welfare counterparts? For the legal professionals, how do you work with both your child welfare and your treatment counterparts? So in an effort to establish some fundamental basic training, these online tutorials are available for no charge as part of the National Center on Substance Abuse and Child Welfare. And one of the tools that are available to you is some participant workbooks and supervisor handbooks that we developed through collaboration with the state of Utah. Just as a quick side note, we had found out that the state of Utah had started using our child welfare worker tutorial statewide as part of their foundational training for their child welfare workers, and they noticed that, or they wanted to take the extra step to not just have their workers take the online tutorial, but they wanted their supervisors to be involved, and they wanted to take some extra steps to make sure that the knowledge that was being gained through the web-based online tutorial was actually being implemented in practice. So they took the initiative to develop some workbooks and supervisor handbooks for that particular tutorial, and then we worked with them to create some similar workbooks and supervisor handbooks for the Guide for Substance Abuse Treatment Professionals. The idea being that the web-based component can and does provide some very foundational knowledge, but it's based on a national perspective so that it can be utilized by any individual state or county or tribe or community to then be leveraged as part of in-person direct work, direct training or supervision in a way that supports ongoing knowledge acquisition and application of actual practice improvements. Here are some, just a quick screenshot of what the online tutorial looks like and a link to how to get there. And then the workbooks and handbooks are available to you as PDF documents. And again, all of this is available for free for adoption and adaption, adapting in your local community for how you'd want your individual counselors or workers to be integrating their knowledge into direct practice. And again, just as a quick note, the online trainings are available at no cost. There's a certificate available upon completion, and then there are also CEUs and CLEs are available, depending on which tutorial you're taking. Some additional resources that are available as well. In particular, I just want to highlight Helping Child Welfare Professionals Support Families with Substance Use, Mental Health, and Co-occurring Disorders Toolkit. We have a trainer's toolkit that's available on the National Center website that is, it's got 6 modules of training. Each one has their own individual PowerPoint presentation, trainer script, handouts, case vignettes, discussion activities, interactive tools, that website links, so that any of this information contained in that toolkit can be customized by a child welfare trainer for use in in-person training settings for new or ongoing workers. And currently we're supporting the states of Connecticut and New Jersey in adapting this toolkit for implementation in their ongoing child welfare training plans. So again, another toolkit that you can use that is available through as part of the collaborative practice model. Okay, and the final element of collaboration, achieving positive outcomes for children and families, shared outcomes and joint accountability. And this is inherently connected to screening and assessment, to engagement and retention, and to data and information sharing as well, because you'd want to make sure that as a collaborative group, if you're identifying what outcomes you share in common, that you have the ability to do the appropriate screening, assessment, engagement, retention, and then data and information sharing to identify whether or not you've been successful in achieving those outcomes, and then how do you hold each other jointly accountable for all of those pieces of the work. Just as a quick review that we do as part of our training and technical assistance, some of the outcomes that substance abuse outcomes for parents involved in the child welfare system, some outcomes to look at for joint accountability are access to treatment, retention and treatment, positive discharge from treatment, reduction in substance use, change in employment, and change in arrest. Some child welfare outcomes for parents with substance use disorders are children remaining at home, occurrence of maltreatment, length of stay in foster care, reentries in foster care, and timeliness of reunification or permanency. And then other important outcomes, clearly child well-being, adult mental health status, including reduction in trauma symptoms, school attendance, parenting skills, family functioning, risk or protective factors, and children and parents connected to supportive or ancillary services. So I review this to say that, again, here are a couple of very concrete ways to identify what outcomes do each of your partners, or are each of your partners invested in? As their individual agencies at the state or local level, what outcomes are they attempting to achieve as part of their mission and mandates, and how can you review as a collaborative group each of your individual mission and mandates and anticipated outcomes, and where can you create some areas of agreement for having some joint responsibility? So for example, children remaining at home and length of stay in foster care or reentries into foster care, how is that inherently tied to access to treatment and retention in treatment services, including positive discharge from treatment and reduction in substance use? If you as a group agree and understand that those are connected, then that opens up the conversation to then how are you sharing with each other your ability to achieve those outcomes, and discussing then how are you jointly responsible for supporting each other's outcomes. And we've got some examples of how other sites have identified some shared accountability and for joint outcomes. And some, in this case, some data and logic model examples of how to look at activities, inputs, and outputs for outcomes that can be shared across systems. Okay, so rounding out our time for the day, I'm just going to briefly review the National Center on Substance Abuse and Child Welfare, and at this time I'm going to invite anyone to pose any questions in the questions log. So again, on the right side of your screen, you should see a questions box, and if you click on the little plus by the word questions, it'll drop it down so that you can type in any questions that you might want to submit. And while I review the National Center on Substance Abuse and Child Welfare, feel free to submit some questions that I'll respond to as soon as I wrap up in about 5 more minutes. So the National Center on Substance Abuse and Child Welfare is operated by Children and Family Futures with the mission of bringing systems together for family recovery, safety, and stability. The mission of the National Center is to develop knowledge and provide technical assistance to federal, state, local agencies, and tribes to improve outcomes for families with substance use disorders in the child welfare and family court systems. And the National Center is funded jointly by the Substance Abuse and Mental Health Services Administration, Center for Substance Abuse Treatment, and the Administration on Children, Youth, and Families, Children's Bureau's Office on Child Abuse and Neglect. So at our core, the National Center is not only funded by 2 separate federal agencies, but again, our mission is about bringing together multiple agencies, substance abuse treatment, child welfare, and family court services. The goals of the National Center are to improve outcomes for families by promoting effective practice and organizational and system changes at the state, local, and national levels, to develop and implement a comprehensive program of information gathering and dissemination, which is related to the development of the collaborative practice model. The collaborative practice model that I reviewed for you today is a culmination of information gathering and dissemination that we've accumulated as Children and Family Futures over the last decade of operating the National Center, as well as all of our other training and technical assistance projects. And as the National Center, we provide training and technical assistance. The objectives of our technical assistance is to share knowledge across systems, including primarily substance abuse, child welfare, and the dependency court, but that also includes obviously all of the other related and critical service agencies like mental health and domestic violence. We serve to promote understanding of cross-systems issues and to advance cross-system collaboration, to increase awareness and adoption of cross-system approaches, and to facilitate communication across systems to improve outcomes for children, youth, and adults. Our technical assistance includes the application of collaborative practice and policy tools. So all of the collaborative practice and policy tools that I've outlined for you today as part of the collaborative practice model are part of the training and technical assistance that we provide as the National Center, as well as information and sharing of different models, which again, models are highlighted in the collaborative practice model for your review, and we welcome any questions or comments about those models, and we can connect you with experts in the field for consultation and research. And again, developing issue-specific products, like the collaborative practice model, other white papers and monographs and publications, which are included in the PowerPoint and are highlighted in the practice model. The training resources, including the online tutorials that I reviewed and the training toolkit. And then we do have some opportunities through the National Center to provide some longer-term strategic planning and development of protocols and practice models. We have a program of in-depth technical assistance where we invite states and counties and tribes to submit an application for where we can assign a consultant for a designated time frame to facilitate that strategic planning and development of protocols. So if you have any further questions and follow-up from this webinar, or have any need for additional resources or products, or would like to request technical assistance, you can go to our website at nationalcenter.samhsa.gov, and also to the email us at the National Center at cffutures.org and CSACW at cffutures.org. Okay, I'm going to take just a second to look at the questions that have come in. Okay, so we have a question. Why isn't mental health included in the collaborative model? We have the collaborative practice model is, again, about family recovery, safety, and stability, and we certainly recognize and have provided throughout the collaborative practice model examples of mental health service system incorporation into collaborative practice. Yes, the core systems that are highlighted in the collaborative practice model are substance use treatment, child welfare, and family courts. But in many of the examples and tools and resources that are provided throughout the collaborative practice model do include mental health services. For example, the substance abuse, the child welfare training toolkit as one of the training resources is specifically focused on helping. Actually, I'll go back to it real quick. Child welfare training toolkit is specifically geared toward helping child welfare professionals support families with substance use, mental health, and co-occurring disorders. And again, this is the resource that has 6 modules of training, PowerPoint presentations. It has modules specifically on mental health, specifically on substance abuse treatment, and then on co-occurring disorders, and then how child welfare workers can work with their mental health and substance abuse treatment colleagues to enhance collaboration and share information and provide appropriate screening, assessment, and engagement in services for families affected by substance use, mental health, and co-occurring disorders. And as both Children Family Futures and the National Center on Substance Abuse and Child Welfare, we have recognized and that over the last couple of years as state and county level agencies are looking to streamline services, there has been a considerable effort in many jurisdictions to combine substance abuse and mental health services into joint agencies where they're both served under one one umbrella organization as opposed to as individual agencies. So certainly as we move into the next iteration of the collaborative practice model, we will be seeing a lot more of the integration of substance use and mental health as well. Okay, next question. Has there been any data review of work done on to track how systems coordinate to ensure children and parents receive visits even when the parent has not completed treatment? You know, I am data review in particular. I know that we are working with a group of regional partnership grants who are certainly looking at some of these data elements. So I don't have available off the top of my head data review on tracking how systems ensure that children and parents receive visits even when parent has not completed treatment. But I know that there are many states and counties who have developed protocols and policies about ensuring visits for children while the parent is still in treatment. One of the basic tenets of that, and as part of overall outcomes for child welfare, for the child welfare system, is that the number of visits that children receive is directly tied to the success of reunification services, and that understanding of that connection between type and quality of visits and the ultimate outcomes for children is certainly something that I know is an important topic that is being discussed. So if I'll send out some information on that item in particular. All right. Well, again, as part of the presentation materials, you have our contact info and email address. So please feel free to email and follow up. And if you'd like to request technical assistance, feel free to do so as well by both going to our website or emailing us directly. Thank you very much for your time today. When the webinar closes out, you will be prompted to complete an evaluation of this webinar. So please complete our evaluation, as that helps us to improve our trainings and webinars in the future. And we have another couple of post-national conference on substance abuse and child welfare in the course webinar series webinars scheduled for July and August. So we look forward to having you join us at our subsequent webinars. Thank you very much, and have a great day, everyone.